let's quickly learn the type of insulin preparations available. So we have short acting, then rapid acting, ultra rapid acting, and long acting. So for the short acting ones, you have the regular insulin, onset between 30 minutes to 1 hour and peak duration 2 to 4 hours. Then for the rapid acting ones, you have the famous glulicine, Lispro, Aspart with onset within 15 minutes and the peak within 30 to 90 minutes. Then you have ultra rapid acting, that is the faster version of Aspart. Then for the long acting ones, you just have to remember gland. GLA is for glargine, N is for NPH, and D is for degludec and detimer. Degludec being the longest acting one with a duration of up to 42 hours. So the insulin is given in two regimes, either the basal bolus regime or the mixed regime. The mixed regime is more comfortable because it needs to be given only twice a day, while the basal bolus is a little tedious task because it needs to be given before each meal and then separately the basal dose at bedtime. Let's learn the rationale behind it. On the y-axis, we have blood sugar levels. On the x-axis, we have time. Normally, for example, the blood sugar ranges between an ideal level of somewhere around 70 to 180. Now, in a diabetic individual, the basal blood sugar level or glucose level is increased as compared to normal people, somewhere more than 200. And each time we consume a meal, for example, breakfast, lunch, or dinner, the blood sugar levels spike. So to handle these, we give insulin. Now we have two preparations of insulin, long acting and short acting. So the long acting insulin is used to control the basal blood sugar level. For that, insulin is given at night time at around 10 p.m. The glargine, long acting one, which keeps the basal blood sugar level as near normal as possible. And to tackle the post meal spikes, we give short acting insulins before each meal to reduce the spike to as low as possible. In general, the patients with type 1 diabetes require 0.3 to 0.7 unit per kg of insulin daily, divided into multiple doses, with 50% as bolus, that is preprandial, and 50% as basal dose. Now, for the meal component, that is the bolus dose, you calculate the insulin to carbohydrate ratio, which is usually for type 1 DM, 1 unit for every 10 to 15 gram of carbohydrate. And to this dose, you add the correction factor that is based on the preprandial blood glucose levels, which is usually 1 unit for every 30 to 60 milligram per deciliter above the preprandial target, and it can also be calculated by 1500 divided by total daily insulin dose.